So switching gears to CAD. So these next couple slides are all about CAD. What is CAD? That's coronary artery disease. I mean, yes, it could be carotid artery disease, but coronary artery disease, the heart arteries are at risk of being blocked. So we have our coronaries are blocked here, and they are unable to receive flow. And no flow means definitely you're going to have angina. What is angina? That's chest pain. Definitely having chest pain. And a lack of flow means you have a risk for an infarction. So an infarction is a tissue death due to inadequate flow. And why is it dying? Because there's no oxygen. Yeah, there's no glucose too, but there's just no flow to that tissue, and the tissue can die. It can die partially, or it can die all the way through in the heart. And that's the difference between an NSTEMI and a STEMI. So these guys are under the umbrella term of coronary artery disease, and then we have another umbrella underneath. So usually you can survive with coronary artery disease, and you can be walking around with coronary artery disease, and as you're walking, you may get chest pain. That's called, what happened? That's called, I didn't put any kind of transitions in here. Anyways, if you're walking, and you get chest pain, that's called stable angina. Is that coronary artery disease? Yes, that's a symptom of coronary artery disease. But what's worse than just walking, get chest pain is lazy boy chest pain, right? That's just where you're just sitting there, oh, chest pain, what the heck? Or you're sleeping, 3 a.m. That's when the most MIs get called. You're sleeping, and all of a sudden you have the Simoji effect or something. You have hyperglycemia happening. Your SNS is firing off, and then bam, you get a MI. Okay, and that chest pain at rest is called unstable angina. So the difference between stable and unstable is what? Is timing. All right, so is it at rest? That is which one? Unstable. If it's just with activity on exertion, that's called stable chest pain. And we have to define, like, is that chest pain with, is that cardiac chest pain? So we'll describe what cardiac chest pain looks like, right? So the myocardial oxygen demand is requiring a lot of oxygen. You're walking, you're Vasquez rocking, I don't know. You keep going, you're doing things that require activity, and your heart's requiring a lot of oxygen, and then these vessels right here can't keep up because they have narrowing, right? They have ASCVD, and they are activity limited because of that. Okay, so what can we do? We can vasodilate them. We give a little medication to open them up more. So what medication is that? We give this medication. Oops, that's not a straight line at all. So let's go erase that one. No one ever saw that. All right, so you have this baseline vessel, and let's go ahead and make it mondo. Let's go ahead and vasodilate it out, right? What medication is that? That's NTG. What is NTG? Nitroglycerin. So we'll talk about nitroglycerin, how to teach someone how to use it in a couple slides. So nitroglycerin is a medication that's is a nitrate. Whenever you have a nitrate, it vasodilates everything, including the coronaries. By everything, I mean everything. It's going to be the veins and the arteries. It's going to dilate all those things. So that puts them at risk for what vital sign derangement? Low blood pressure. So before you give nitrates, you should be checking blood pressures. All right. So results with rest and nitrates. So that's kind of what stable angina is. Stable angina is like, oh, I got this chest pain, and then they sit down and they take their nitrates and it goes away. What if it doesn't go away all the way? What's it called? So that's another feature of unstable angina is they're walking, they get chest pain, they take nitrates, it doesn't go away. Well, sir, you have unstable angina. What should they do? They should call 911. They should get investigated, right? They should be looked at to see, hey, do you have EKG changes? Is your ST elevation up or down, right? If ST elevation is up, what do they have? ST elevation MI, right? Myocardial infarction. So what else? So this is an acute event. This is an acute coronary event now. They had coronary artery disease, that's an umbrella term, and then now they have to go to the hospital. And when they go to the hospital, they're going to say you either have unstable angina or you have stable angina. Sorry, you have unstable angina or NSTEMI or STEMI. Those are your three options when you have acute coronary syndrome. So those are kind of, it's a few little layers there. All right, so unstable angina, that is, again, what? That is chest pain at rest, right? No exertion required. And a little caveat there is they might have had walking chest pain, but then the nitrates got better. Am I going to test you on little caveats? No, I'm going to test you on the big stuff, right? As you probably knew today. So what else? We got what else on unstable angina? This it's kind of a gray area, unstable. It's like, I don't know, we can't figure it out. They're going to do more tests, and then they might find out that you have an NSTEMI or STEMI, right? So what is an NSTEMI? That's an MI that does not have a STEMI. So it's a non-STEMI. So if STEMI is ST elevation, everything else is non-STEMI. That's just that's what it is. Okay. And there are some caveats. If you are in the cardiac, there's like 9 equivalents to a STEMI, but we're not going to talk about that. That's maybe Med-Surg 3. But either way, we have partial wall damage, right? Part of the wall is damaged, and we get ST changes. If you want to know why, ask me in clinic or ask me somewhere else. I'll tell you exactly how it looks like that, right? But STEMIs, they cause ST elevation. That's the full wall is not working, and that's going to be an emergency. That requires immediate opening of their coronary vessels. How fast? 90 minutes. So once you identify that they have a STEMI, usually from the door to the time they open it up, which is they use a balloon to open it up in the cath lab, that's 90 minutes, right? You'll talk more about how to fix STEMIs and NSTEMIs in Med-Surg 3. Right now, you have to know that's a possibility. That's a complication of CAD, right? A complication of CAD is ACS. What is ACS? One of these 3 things, right? How do you know that you have those 3 things? You have what are called troponins, right? And we'll talk about the troponins. That's a diagnostic test you can do, right? When liver cells split open, they spill their what? Into the bloodstream? They spill their enzymes called alanine aminotransferase, which is called ALT, right? And aspartate aminotransferase is AST. So yeah, AST, ALT gets spilled into the serum, and now you know, oh, you got liver damage. But how do you know you have cardiac damage? Well, troponins are found in, yes, all muscles, but there's cardiac-specific troponin that we can measure, right? So we can measure that cardiac-specific troponin, and we can say, hey, your cardiac cells are dying here. They are infarcted, so they are infarcting, and they will 100% die if we don't intervene right now. Okay, and then of course, how do we find out that you have an ST elevation or an ST depression? The patient feels it. You know, sir, I'm feeling like some ST depression right now. So you did an EKG. So you did a 12-lead EKG. So part of when someone comes to the hospital with acute coronary syndrome is they should probably get an EKG and a troponin, right? We have this other type of angina, which is vasospastic. That's where it's not ASCVD related. It's just they vasospasmed because they took cocaine. Or they have, there might be some smoking reasons. There's some other inflammatory reasons that might do it, but usually it's cocaine. All right, so you can see here, look at this vessel right there, that is blocked, right? We need to open that up right away. And we open that up where? How do we open it up? Do we open up the bedside, like a big knife, scalpel? How's that done? That's done in the cath lab, right? You go to the cath lab now. This patient probably has an NSTEMI because they got some partial flow distally, right? But once that blocks all the way, now you're at risk for an infarction or STEMI. All right, so chest pain. What is chest pain? What is cardiac chest pain, right? Because it's going to get people's attention a lot more than just saying, oh, my chest hurts, or I got some chest discomfort, right? So what is stable angina? That is when they have chest pain when? They got chest pain on exertion. So chest pain on exertion is stable angina, right? So how does that chest pain, what does that chest pain look like? It is substernal. So where's your sternal at? That's your sternum, right? So below the sternum, that's where the pain is, and the pain radiates to the left arm. Sorry, and the pain is also described as pressure. And what everybody says, even like in a foreign language, it feels like an elephant on my chest. Why is that universal, right? No one told them elephant, right? You could say kookaburra, right? They'll say, oh yeah, is that a heavy animal? No, but everybody says elephant, no matter what the language is. It's an elephant sitting on my chest. Right, it's pressure, not burning. Burning is not MI pain. If it is sharp, that is not MI pain, right? These are all your PQRSTs of pain assessment, right? What is the quality of the pain? All right, if it's sharp, burning, or positional maybe, those are not MI pains. Those are not ACS pains. Those are not anginal pains. So it's pressure, and also it's pain that radiates. That's very, very common that it will radiate. Sometimes it doesn't, that's fine, but it's pressure that radiates. And it radiates commonly to the left arm or both arms, and also the jaw. So that is a feature of cardiac chest pain. Someone says, I got some pain and it's radiating to my jaw. I was like, hold Well, tell me, does it feel like pressure? Yeah, it feels like an elephant. How'd you know about elephants, right? So yeah, so that's an elephant on the chest. It's radiating. It's pressure-like. That is cardiac chest pain. That's anginal chest pain. And then you'll have SNS symptoms because you have pain, right? Pain's a feature of an SNS firing off. Everybody get that question right? Right. So pain also causes tachycardia, sinus tachycardia, SVT, all the tachy's. So that's going to be making your heart rate elevated. They're going to be very diaphoretic. They're going to look really bad. They're going to say, I don't feel so good. All right, I feel like I'm going to die. So we'll shoot. Let's take a closer look at you. All right. So the other thing I would tell you have cardiac chest pain is is brought on by exertion. So exertional chest pain is stable angina. What if it was just brought on at rest? That's unstable angina, right? That's the same. Angina. But how do you know if it's stable or unstable? Is whether it was brought on by activity or it just happened at rest. So brought on by activity means what? What kind of angina? It's stable angina. Okay, unprovoked or sudden onset. All of a sudden, they're just sitting there watching the game, and bam, they got chest pain. It feels like an elephant's on their chest. It's radiating to their jaw and both arms. It's like, and they're feeling anxious. Like, I feel like I'm about to die. Right? That is unstable angina. It could be. It's really acute coronary syndrome because unstable angina is there, and then we got unstable angina, or we could have MIs. And how do you know you have an MI? We're going to do some diagnostic tests. We're going to do troponin levels and EKGs and a few other things. We'll talk about the diagnostic tests. All right, the third thing, so if you have 3 out of 3 of these things, really you can really seal the deal and tell the doctor or the provider that, yeah, this is something serious. It's time to wake up. It's 1 in the morning. We need to get this fixed right now. All right. So as a new nurse, you have to know these things so that you can, it's like, oh, it's nothing. I'll just wait until the morning. And then you give reports like, yeah, he had some chest pain last night. Oh, what was it? Does he have some indigestion? No, it felt like he said he had like an elephant in his chest. He said he was going to die. And he said that, it was right into his jaw and both arms, really. It was really weird. So as a new grad nurse, you should be able to recognize that that is an emergency, right? That is something that needs to be fixed right away. Would you agree? Yeah. All right, so that's why we're teaching it. All right, and then relieved by rest or sublingual nitro. So sometimes people with stable angina, they're walking, they get chest pain, and they forgot their nitrates maybe. That's not a good thing. That means they didn't listen to their nurse. But then we can give, they might just go away with just sitting down. Like, oh, now my chest pain's better, right? Or they need nitrates. They need nitroglycerin to be given to get their chest pain under control, all right, to vasodilate and hopefully provide more blood flow to their heart. Okay. So beta blockers can be given to kind of reduce that SNS response. If the SNS is firing off, does that put more stress or less stress in the heart? It puts more stress. So usually we can give beta blockers as long as they don't have CHF. CHF AE, we'll talk about later today, that's an acute exacerbation of CHF. So someone comes in with all this chest pain and they got both legs swollen, they got crackles up to their nares, and they have a history of CHF. It's like, well, we probably should not be giving beta blockers. Beta blockers are contraindicated with CHF. Okay, and then calcium blockers. We can give calcium blockers, but again, CHF, we're going to avoid that. Calcium blockers will vasodilate and help reduce the O2 requirements of the heart. All right, so then other symptoms. What else might tell you have some chest pain happening that might be getting worse? They got a CHF symptoms. Why would you have CHF symptoms? Why would your heart be failing if your heart's not getting blood flow and its oxygen is deprived and the muscle can't work good? For that exact reason, right? So if you have an MI, you can start getting CHF symptoms. And you got to get it turned around, otherwise that CHF might be permanent, right? So they might have CHF symptoms, right? It can be what's called a poor output state. That means the heart is not putting out cardiac output. So they have poor cardiac output, and therefore blood flow is not going to the extremities. It's not going to the kidneys. It's not going to the brain. It's not going to the skin. So you get some cool skin, but also you get clammy skin because what happened? The baroreceptors started firing off because there was no flow, right? The blood pressure was low, and the SNS kicked in, right? So you have the chest pain shortness of breath, hypotension, and confusion can happen. All right, so what else? We got then what is not cardiac chest pain? They say it's pleuritic. I mean, what does pleuritic mean? It hurts when I breathe, all right? So stop breathing. Did it go away? Yeah, it went away. Can I breathe now? So that would be not the heart, that would be the lungs that are causing the problem. Whenever they take a deep breath, oh, it hurts. That is pleuritic chest pain. What about positional? So it hurts when I lean forward. Well, what about when you lean back? Does it hurt also? Well, that's not cardiac chest pain. That is something else, right? Such as pericarditis. And then what else? We have it's not reproducible by palpation. Does it hurt when I touch right here? Or the patient says, hey, it hurts when I touch right here. I got chest pain. When you stop touching, does it hurt still? It's like, no, it went away. All right, well, A, stop touching it. But also B, it's not something serious right now, but we'll still do all the things. We'll still do the diagnostic tests and make sure it's nothing serious. All right, so then acute coronary syndrome, that can happen from stable angina, can progress to that, but stable angina and ACS are all under the same umbrella of what? Coronary artery disease. So stable angina, usually outside the hospital, and there's some other versions of it, like or there's Prince metal angina, but ones we're going to focus on are stable angina that can progress to unstable angina, which can be either NSTEMI or STEMI. Right? So those are what's happening with a patient that has acute coronary syndrome. They have chest pain always at rest, right? So they also have EKG changes. Do you have to know all the EKG changes? No. You just have to know that it's either ST elevation or depressed. That's a clue that they have something going on. And also the troponins are going to be elevated, definitely in STEMI and STEMIs, but in unstable angina, it may or may not be elevated. It's just we got to do some more tests to figure it out. Okay. So what is this one right here? ST elevation or non-ST elevation? That is a STEMI, right? So the ST segment is elevated. If it's not that, it's NSTEMI. All right, so chest pain and the other things that could be. So what if you got to think of more serious things than a heart attack? Like people say serious is a heart attack, but what's more serious than a heart attack? A dissecting aneurysm. So that's probably what the phrase should be changed to. So we have a aortic dissection is something is even going to kill you even faster, right? So we want to say, hey, did the chest pain happen all of a sudden? Well, it happens in unstable angina all of a sudden, but is it a tearing pain, right? What kind of pain is regular anginal chest pain? Is it tearing? No, it's pressure, right? So if it's tearing chest pain, it's sharp, and it's radiating to the back, that is an aortic dissection. And that's a complication of hypertension, which we'll talk about next week. All right, so we're going to kind of get you a little taste of it right now. Also, we do an X-ray on everybody that gets comes in with chest pain because if the aorta above the heart separates, it's going to start bleeding into that space. And what's that space called? That the heart sits in? The mediastinum. So on the X-ray, we can see, hey, the mediastinum is widened. That means it's filling up with blood. All right. Also, if it's the three branches off the aorta. 2 of them go to the head and 2 of them go to the arms. There's only 3 branches because one of the branches kind of doubles up. But if you have an aneurysm like right here, for instance, right, the right arm is fine, but the left arm is not getting blood flow, right? So a difference between the arms on blood pressures is really going to be it's like 85%, 83% likely that you have an aortic dissection. Okay, and then how do you know someone has aortic dissection? Hypertension. Right? Cocaine is hypertension in a bump. So, and also exertion can do it. They can twist or they can have trauma. And we'll talk more about aortic dissection next week. But then pericarditis, we'll talk about that. I think I'll probably give that to you as study, self-study, but pericarditis is positional. So is positional cardiac chest pain? No. So it's positional. It is not likely to be cardiac or anginal chest pain, I should say. All right, it still hurts under the chest, but it hurts when what? When I lay back. When I lay back, all my sternum, all my lungs, all push on my pericardium, and now my pericardium hurts. Right? But if I lean forward, that loosens things up, and now it improves. All right, so if it gets better with position, that's not cardiac chest pain. All right, and then friction rub is a characteristic of pericarditis. And then lungs. So we'll talk some of these lung things you heard already, pneumothorax. They have chest pain with that. And you can auscultate them, and you can listen for what? Listen for nothing. You hear nothing on one side. That is a sign of a pneumothorax, right? And that can develop in what's called a tension pneumothorax. And we'll talk about tension pneumothoraces with a pericarditis as well. That's one of the complications of pericarditis. All right, pneumonia can develop a pleurisy. It's pleuritic chest pain. And what does that mean? It hurts when you breathe, right? When someone comes with a heart attack, they don't usually come with a fever. and sputum production. That's not usually, you can have both at the same time, but we're kind of deleting one or the other, right? So we're testing you on one or the other. We're not going to do fancy tests like, oh, they got all these problems. What are you going to do? So we want you to figure out, is it cardiac chest pain or not? Okay. And then pulmonary embolus. So we talked about that with AFib, right? But you can get clots with, yes, AFib. And AFib is caused by what? What's an important reason for AFib? Important cause? Atrial enlargement, which can happen with CHF, right? Which can be a result of an MI, which is a result of ASCVD. So they can get a pulmonary embolism, and that's going to put strain on the heart. You might get a troponin that may be positive, but you're going to look at their history, like they're bedbound, they didn't take any anticoagulants, they don't have any SCDs on. That might be a reason why they have a PE. All right, there's other reasons. So aortic stenosis we'll talk about with valves. So our aortic valve is not is stenose, it's closed shut, it's scarred and calcified. Vasospasm we mentioned, that's Prince metal with drug use. Costochondritis means you were coughing all night and your ribs hurt, right? And GERD and gallbladder stuff, we'll talk about next semester. When you have burning sensations, and burning like acid reflux and ulcers that are eating away at your stomach. And just fun fact, stress does not cause ulcers. So that's not going to, so just you can look forward to that in nursing school. And then what else? Biliary stuff and pancreatitis. This is all next semester, but that's GI is an important reason to differentiate. Say, do they have cardiac chest pain or is it just something GI? Right? You're still going to do the test to make sure it's not cardiac. Okay. So quality. So these are PQRST, right? What provokes it? So what is cardiac chest pain? Is it provoked? You could say it's provoked by exercise and activity, but like poking at it, no. If you're poking at it and touching it, all right, that's not cardiac chest pain. But if it just happens all of a sudden, or if it happens with exertion, with activity, that's a characteristic of cardiac chest pain. All right, the quality. What kind of quality is a cardiac chest pain? It's pressure. It's not burning, tearing, right? It's not sharp. It's not pleuritic. And then duration. Does it happen after a meal? Well, it's probably not cardiac chest pain. Yes, that's a lot of work sometimes, but it's not. That's not what we're talking about here. All right, and then location. Is it localized, one spot, or does it radiate? Usually, which one radiates? Usually, cardiac chest pain radiates. All right, and also, if you have the chest pain, you give nitrates, it doesn't respond. It could be GI chest pain, or it could be something else. But that's another piece to it. All right. Also, the thing is, men, they need clear signals, right? They need to know exactly what's going on. So men need to know, they usually have the typical symptoms. That's compared to women. Women have a little more elusive symptoms. So they might have just like back pain, for instance. They might just have some, maybe some slight discomfort, not as prominent as male presentation. All right. So men are all the classic symptoms like we mentioned. All right, so when you're getting chest pain assessment from someone, sometimes it's a little bit difficult.
Hey, sir, I hear you're having some chest pain. Why don't you tell me what's going on?
When I was a young boy, my father took me into the city to see a marching band.
You know, that story sounds amazing, and I really would love to hear the end of it. But if you could just dial it back to today, and specifically why you called 911 now.
All right, so yeah, you might have to lead the conversation. Tell them, hey, does something feel like something sitting in your chest? What does it feel like? An elephant. All right, so diagnostic tests. All right. So diagnostic tests, again, we said if they come with a chest pain, we want to make sure it is not the worst case scenario, which might be an MI. It also could be a AAA or an aneurysm that's ruptured. So that's why we get that X-ray. Right? That X-ray will tell us if that is not as a ruptured aneurysm. So that the chest X-ray shows widening, that could be a situation. Right? Also tells you if you have pneumonia, that could be the reason for the chest pain. And then EKG, it's only 60% accurate. It's better than a Hohmann sign, that's good. But it's only 60% accurate. So when you do an EKG and someone, oh, sorry, you don't got chest pain. That's not true. You have to do the whole deal, right? And sometimes they'll do another EKG in an hour, another EKG when the chest pain is worse, right? And pericarditis has some ST changes as well. So that's something to take note when we talk about EKGs for pericarditis. The echo is our bread and butter for cardiology. It's usually every cardiologist, when they come by and they see the patient, they say, oh, we're going to do an echo, because it's usually everybody starts with an echo. So echoes and EKGs are usually everybody gets one of those. So if they come in there for something cardiac, they're probably going to have an echo done, or if they need one done. And the echo is going to look to see if they have something going on in the heart, right? If you don't have blood flow to your muscle, is your muscle going to work good? Right? So the muscle doesn't work good, so you can see that on an echo. You can see wall motion abnormalities. Well, why is it abnormal? Because it's not moving, right? So you can look to see if that's happening, and that reason why it's not moving could be an MI. You can look to see if there's valve disease. If there's a valve issue making them not be functional, like aortic stenosis is usually the worst one out of our valve diseases. And then about ejection fraction. We'll talk about that with CHF. We'll look to see if how much blood the heart's putting out is effective or not, if it's a good test score or not. And a good test score for ejection fraction is 55 to 70%. Unfortunately, it's not passing in nursing school. 55 to 70%, it's a good ejection fraction, right? It is a good ejection fraction. And then CT chest. So CT chest, we light up the chest vessels and we see if there's a blockage. What could be blocking the vessels in the chest? Could be a pulmonary embolism. Okay. And then cardiac stress test. So if the above wasn't conclusive, they might do a stress test in the hospital, and the stress test could be done in a treadmill, right? And who can't do a treadmill stress test? Those who can't treadmill. So please don't learn all the possible contraindications of treadmills. Like they are BKA, they below the knee amputation, they cannot do a treadmill stress test, right? If they have like 5 different comorbidities, they probably are not doing a cardiac stress test, right? So try to think about it overview, right? So oftentimes people are going to get a chemical stress test where they get a stimulant that's going to mimic exercise and make the heart rate go fast. Okay, and then angiography. So that's like a definitive test. They go in and they actually look at the vessels of the heart and see if it's open or not. If it's not open, while they're there, they can open it up. Right? They open it up with stents. So you can see the cardiac cath lab on the left is a vessel that's occluded, it's blocked, right? So it's blocked in many little parts there, and this part is all gone, right? And then over here they put some stents in, right? And now they open it up. Now you have flow to your heart. Okay, and then so it's also a diagnostic test, but also can treat. So that's a bonus for angiography. All right, and then what about biomarkers? So biomarkers are things that spill into the blood, and one of those things for the heart is troponins. So troponins, they used to have just regular troponins, but now we've upgraded to high sensitivity troponins. I think at both hospitals they're high sensitivity, and high sensitivity troponins are just, if you like zoom in on the slope right there, right? You can actually see a minuscule change in their troponins, and if it's going at it changes by a certain amount, I think it's like 12 points or so, that's indicative of that you have a MI happening, right? You're spilling troponins at a rapid rate, right? You used to have to wait 4 hours. It's because it was undetectable before, and you had to wait like 4 to 6 hours before you even saw the first troponin elevated. You're like, I'm feeling chest pain here. I think I might have a heart attack. Yes? Use the old troponin, old school. So yeah, so the old school troponins, yes, they're like a factor of 100 difference, right? So you can see like it used to be 1.2, and now we're 120. So it's greater than 120 on the troponin, you have a cardiac event unfolding. All right, so then there are other reasons why the troponin might spill out. The heart's working super hard. Maybe they have a myocarditis, an inflammation of the cardiac muscle, and the muscle is like dying from viruses. That could be a spillage of troponins into the serum. And then also, what if you have a PE? Which side of the heart would be working extra hard if you have a PE? The right side. The right side is, well, whoa, what's all this extra pressure I have to work up against now? Right? So myocarditis will add to the list as well, myocarditis. Kind of link the last parts of this lecture. All right, so that's the idea with a cardiac stress test and with troponins and such. All right, so how many more slides do we have before our break? I want to get a few more in, and then we'll take a quick break. All right, so we're doing CAD. Just want to double check here. Where are we at? Do we have 2 slides left before CHF? I think we do, right? All right, so we'll finish those last 2. All right, so CAD medications. So medications you would do if someone comes in with chest pain, like we mentioned, was doing nitrates. So nitrates are given PRN. Usually they're not just taking nitrates every day. That's not good. They should be taking it only when they have chest pain. So it's important teaching that we need to give them. So if they need to have if they have stable angina, which is the sign of what disease process? A CAD. Then we need to have them being aware of how to manage their chest pain if it were to happen. And chest pain being what? Like an elephant on the chest. If they have pressure that's going where? That's radiating. Okay, so all of a sudden something happens and the vessel then gets blocked, right, because of exertion, for instance. They have activity. Then we need to give nitroglycerin PRN. And this will be done by the patient. The patient needs to understand what to do, right, and how to take care of it. Because the worst thing is they got the chest pain. It's like, oh yeah, now I got it. I got it 3 years ago, and it's in my glove compartment, and it's been, in an Antelope Valley summer. It's like not going to be very effective at this point, right? So we have to make sure we're teaching them the right way to take care of it as well. All right, so what does nitroglycerin do? It's going to vasodilate everything, right? So this sublingual nitrates means we're giving it where? Under the tongue, and the tongue is going to absorb rapidly, and it's going to then be working on all the vessels, the veins and the arteries, vasodilating and allowing flow to all the vessels, including our heart. Okay, so if it dilates all the vessels, that's going to drop what? Drop the blood pressure. So every time we give the nitrate, or any blood pressure medication in general, we should be checking the blood pressure, right? So the blood pressure is greater than 90, is it okay to give? Yes, all right. And then what's a PDE5 inhibitor? PDE5, phosphodiesterase 5. That is Viagra. So if someone's on Viagra, Viagra also potentiates nitrates. So if we have that potentiate nitrates and then this, give them nitrates, now you have what? Extreme hypotension. It's not just something like, oh, I think that's okay. You took a little bit, like last night, but it's like 3 in the morning. You're fine. It should be gone by now. You have to wait how long? 24 hours. So 24 hours needs to be elapsed before you can give nitroglycerin sublingual. Otherwise, it causes life-threatening, deadly hypotension, otherwise known as a test question, right? So that because that's a big safety concern. Are you taking what? Erectile dysfunction meds, right? So then also storing of it. It needs to be stored in the container, protected from light and heat, right? It loses its efficacy if it's out it's like in a Ziploc bag. They show me your nitrates. And they show a little Ziploc bag. It's like that's not the right one. Okay. So these are examples of what to teach, right? Should they swallow the sublingual dose? No, they should be taking it sublingual. And then they need to make sure that they are storing it correctly, making sure it's stored where? Why in the container? Because the container is a way to protect it from light, right? If you store it in a cool place, it should be stored nearby, right? So nearby being where? Like on the keys right here. So you can buy that on Amazon to store your nitrates, right? Store your nitroglycerin tabs. All right, so that's the idea with nitrate therapy. And how is it given? It's given every 5 minutes. Times how many times can you give it? 12 times, 10 times? 3 times. So after the 3rd time the chest pain hasn't gone away, congratulations, you now have what? Unstable angina. You need to call 911. All right, if nitrates don't relieve the chest pain, that is definition of unstable angina. Okay, so it's important they call after if the pain is not going away. All right, and so that's something that they're going to take PRN at home. What else would they take? So someone came with ACS and now they're being discharged from the floor, from the tele floor, what have you. What should they be on? They should be on things that what? I'm not going to do it, but they're going to adapt, right? They're going to adapt abs is the mnemonic for what every patient should be discharged with. So DAPT meaning dual antiplatelet therapy. So DAPT meaning they have aspirin, that's antiplatelet, right? And next week we'll talk about everybody's favorite thing, platelets and the coag cascade. But so we'll talk more about DAPT next week. But DAPT, they're on something that's going to inhibit the platelets in 2 different areas. So we have aspirin inhibits in one area, and clopidogrel, for instance, which is a P2Y12 inhibitor. That one is going to also inhibit the platelets. Because why do you want to inhibit platelets? As someone who has ASCVD. That's the whole reason for an ASCVD event, right? For a heart attack, for instance, for a stroke, for a peripheral arterial disease complication, right? So we want to stop the platelet from deforming and becoming activated when it sees the collagen being exposed inside the atheromas. All right, so DAPT is the first thing your patient should be doing. It's like, you need to DAPT for me. Please DAPT. right? And then the next thing is they can show me your abs, right? So abs are meaning that they are on an ACE inhibitor or an ARB. Either one is fine. ACE inhibitors are better and stronger. They're going to have better effect. But ACE inhibitor are ARBs, and then they need to be on a beta blocker. So which beta blocker? MBC is what are the 3 you need for ACS and also for CHF. So that's nice, they overlap. Those are the 3 beta blockers that they'll be on, because there's a lot of beta blockers out there, right? So when they're discharged, they should be on one of those 3. And then it's not BBs, it's it's not the S in ABS is not like beta blockers. It is ACE inhibitors or ARBs, B for beta blockers, and S for what? What's the bread and butter for ASCVD? Is statins. So they need to be on statins. So there's a beta blocker, ACE inhibitor ARBs, and they need to be on dual antiplatelet therapy. Those are things as a safety net to make sure they're on all these things before discharge. Otherwise, they're going to bounce back with another ASCVD event. Okay. So bleeding risks and such we'll talk about with our DAPT. They're on 2 antiplatelet drugs. They're going to have a high risk of bleeding. And we'll talk about that next week when we talk about all kinds of anticoagulants and antiplatelets. All right, so that's what they need to be discharged on as far as coronary artery disease. And when you have an MI, your muscle needs to repair itself, right? It needs to go back to where the way it was before as much as possible. And guess who knows how to make cabinets and knows how to make ventricles? The SNS is going to think it knows how, right? And the RAS system is going to think it knows how as well. And they do not. They 100% do not. They make shoddy cabinets that are going to break on them. So we give beta blockers and ACE inhibitors to stop that from happening. And we'll talk about that more with CHF in a little bit when we talk about the reason why you give these medications. All right, so complications. So we kind of alluded to it, but if you have CAD, it can potentiate into ACS. That's the unstable angina, the 2 varieties of MIs, right? So that's acute coronary syndrome, which is under the umbrella of CAD. And then what happens when you have the MI itself? You have this acute coronary syndrome that can lead to many, many things. It can lead to dysrhythmias, right? They can go into VTAC, VFib, which you took your test on this morning, right? They have thrombosis of their vessel, and that makes that heart muscle very, very irritated, and it's going to be irritated to the point of going to VTAC or even VFib. And it could irritate the atria, cause the atria to be irritated into AFib, for instance. And if you have AFib, well, shoot, now you're at risk for what? For a stroke, right? So then heart failure is our next section. Heart failure is a significant significant complication of ACS, right? So if they have ACS, they can maybe just not have anything going on, or they can have a lot going on. And that can, if they recover and they get all the treatment, they can then end up with congestive heart failure, which is our next section, okay? And then also murmurs. So it's one of our little valves here are held in place by papillary muscles, right? So our papillary muscle holds on to our mitral valve, and if our papillary muscle dies because it didn't get the blood flow it needs, you can have a murmur. Okay, and then murmurs, ironically, lead to heart failure. So because the murmurs are they would keep blood where it needs to be, right, in the right compartment, and if blood keeps getting in the same compartment over and over and over, that compartment is going to start to get bigger and bigger and bigger, dilate, otherwise known as CHF, right? And then that will dilate if it's dilating the atria, that's going to put you at risk for AFib. Okay, and then some other not so nice side effect, nice complications. The ventricle wall can just rupture. It can just explode. And also someone's like on NSAIDs after a heart attack. That's not good because that can also interfere with the healing process, and that will rupture their different walls of the heart. Okay, pericarditis can happen. So we'll talk about pericarditis later. That's a complication of an MI sometimes. It usually happens like 3 months after. And then if that vessel wall, that ventricular wall is dilating out really, really big there, you can start to form a big thrombus inside. So you see this big thrombus right there just hanging out. And that can then be a thrombus in transit, or what do they call it? I think it's thrombus in transit. And that's just it can then include the lungs, it can include the brain, it can cause a lot of problems. You see this one's being bounced just like a little basketball. That's huge and impressive. All right, and then when you have ASCVD or you have an MI, you can have another MI afterwards. It's not, it will be, it's an important side effect to think about. And then also CHF, if they make it out of the hospital, it's like, how bad did that hurt your heart? We're going to look at your echocardiogram to see what your heart function is. How good of a test score did they get, right? And what's a passing test score for the heart? 55 to 70%. Okay, so that's CHF. And then, so again, ASCVD leads to CAD, and then you could be walking around, you're doing fine, you're walking, you get chest pain. And then you take what medication for your chest pain? You were taught correctly. You take your nitrates, right? And the nitrates will then do what to help your heart? They're going to vasodilate the heart, and they're going to provide more blood flow, hopefully. But then what if it doesn't go away? Which they do. Call 911, they call 911, they get to the hospital. They get all the interventions done, and all those interventions and how to do all the timelines and such is all Med-Surg 3. You'll talk about all that stuff. Now we're going to pick it up at the chronic complications. This class is all about chronic stuff, right? So now they could develop CHF, right? They could be chronically walking around with CAD, and they could develop the complications of that, which is ACS, right? And MI and such. And then they hopefully make it out of the hospital, and now we discharge them, and then we follow up with them, and they then have risks of having CHF or valve disease or risk for arrhythmias and such. Okay, so that's the idea with the sequence to get us to CHF.